Seizure is disordered excessive excitation of the cortex, and this excessive excitation is simultaneously synchronous excitation of the whole cortex. On the other hand, epilepsy is when this seizures become recurrent. So recurrent seizures is epilepsy. So that means if a person had one seizure, should we start anti-epileptic drugs? No, we have to look for the criteria whether the person is suitable for the anti-epileptic drugs or not. So there are certain criteria for that. We should note if EEG is showing epileptic form activity. So if EEG is showing epileptic form activity, that means it is a definite criteria. If MRI shows any lesion, brain lesion, then yes, it has to be treated. Third one, if the seizure has occurred in night, nocturnal seizure, because it has a high chances of recurrence. And finally, if there is any prior brain injury, prior brain insult has occurred by means of trauma or CNS infection, that way. So these are the indications for starting epileptic treatment. And remember that if the cause is treatable, then first we have to treat the cause. So there can be cause of metabolic abnormalities. So that has to be treated. Then there can be any focal lesion. Suppose there is a tumor, or if there is vascular malformation, that has to be treated, that has to be removed. Okay. Because if it can be removed, there is no point of giving lifelong treatment with the anti-epileptic drugs. Fine. Now, before we proceed to anti-epileptic drugs, very briefly we will see what are the types of seizures. So seizures are broadly classified into focal seizures and generalized seizures. Focal seizures which are involving only one cerebral hemisphere. Basically their origin is from one cerebral hemisphere. Later on they can spread. Okay. So that is focal seizure, and it is further divided into without consciousness, impairment of the consciousness. Okay. So that is without impairment of the consciousness, and the second one is with impairment. Okay, so before there was another term for these, like focal seizures was known as partial seizures, and focal seizures without impairment of consciousness were known as simple partial seizures, and with impairment of consciousness were known as complex partial seizures. So that is, these are the current names of this focal seizures. Then coming to generalized seizures can be of many types. That is generalized tonic-clonic seizures. Generalized seizures are the one which are arising from the whole cerebral cortex simultaneously. Excitation is arising from the whole cerebral cortex, both sides, in fact, both cerebral hemispheres. Okay, so we have generalized tonic-clonic seizures, we have tonic seizures, we have clonic seizures, we have atonic seizures, then myoclonic seizures, and then we have absence seizures. So what is the difference between all this? That depends on the involvement of the motor activity. Generalized tonic-clonic seizure, there is initially loss of the consciousness, and then there is like this tonic contraction of the muscle, and then there is clonic contraction of the muscle. Tonic seizure, there is tonic contraction of the muscle. Clonic, there is again this clonic contraction of the muscle. Atonic seizure, there is like complete loss of the tone in the muscles. Myoclonic is like a contraction of the muscle which is shock like sudden, there will be shock like contraction of the muscle. Okay, and it can be very brief, like for a second only it will last. And the absence seizure is where visibly there is no loss of consciousness, but suddenly the person is talking, walking, and suddenly he will go blank, he will stare at something, and there may be minor twitching of the muscles, maybe of the eyes, like this. And after the seizure is over, which can last for 3 to 30 seconds, the person resumes his normal activity. There is no post-ictal period. In generalized tonic-clonic seizures and other seizures, there is some post-ictal period, that is after the completion of the seizure to the resumption of normal neurological activity. So that time is known as post-ictal phase, and during this time there is some confusion, or the person may be asleep for hours even because of so much excitation of the cerebral hemispheres. There will be neuronal fatigue. So the person will be confused and may sleep for hours. Okay, so these are generalized seizures. These are the basic fundamental types. Apart from these, there are epilepsy syndromes also, and there are certain unclassified seizures also. Okay, so unclassified seizures include like infantile spasms, febrile seizures, okay, and epilepsy syndromes. I will discuss only about Lennox-Gastaut syndrome. Lennox-Gastaut syndrome is the one in which there is mixed seizures. Okay, so it may be a combination of generalized seizures and focal seizures, and there is loss of cognitive function as well. Okay. Now moving on directly to the mechanism of action of anti-epileptic drugs. So first we will deal with the fundamentals, that how these anti-epileptic drugs act, and then we will go very simplified way the characteristics of each of these drugs and where these drugs are used. So moving on to mechanism of action. So before we proceed to the mechanism of action, very small fundamental we will see about the synaptic transmission, because these anti-epileptic drugs block each and every step of this synaptic transmission. As I told you before that epilepsy is occurring because of excessive excitation of the cortex. So there is imbalance between the excitation and inhibition in the cortex. Maybe the inhibition is less, that is the GABA transmission is less, or the excitation is more, that is glutamate transmission has increased. Glutamate is the most common excitatory transmitter in brain, and GABA is most common inhibitory transmitter, neurotransmitter in the brain. Okay, so first let us see how this transmission is occurring, synaptic transmission. See, the action potential is coming to the neuron terminal, and here there are voltage gated sodium channels. So voltage gated sodium channels are everywhere throughout the neuron terminal, also voltage gated sodium channels are there. So this action potential is leading to depolarization. Because of depolarization, there is opening of voltage gated calcium channels. So this causes influx of the calcium ions, and because of this calcium ions, the vesicles which are there in the neuron terminal, they go and fuse with the presynaptic membrane. So for this fusion, there are certain proteins which are required. They are present on the vesicle membrane as well, and they are present on the neuronal terminal membrane as well. So these proteins, when they interact, there is fusion of the vesicles. So with this, there is release of the glutamate. So this is the synapse where glutamate is released, and this glutamate acts on the receptors which are present on the postsynaptic membranes, and glutamate action depends on three receptors. These are kainate receptors, AMPA receptors, and NMDA receptors. Okay, difference between AMPA and NMDA receptors I have discussed in the video on long-term potentiation that you can watch. Okay, so there are three types of receptors, and glutamate goes and binds to these receptors. These are basically ligand-gated channels as well. Some of these are ligand-gated channels, some act by other mechanism by G-protein coupled receptor. We are not going to discuss that. But with this, what happens that there is excitation in this membrane. Fundamentally, there is depolarization. Okay, basically generation of EPSP, which reaches to the threshold, and there is generation of action potential. Right. Now, there are other channels as well, that is voltage gated potassium channels. Voltage gated potassium channels are important for repolarization. So, depolarization occurs due to opening of voltage gated sodium channels. Then these voltage gated potassium channels open, causing efflux of the ions, these potassium ions, and then there is repolarization with the voltage returning back to the resting membrane potential. So that also we will remember, because there are anti-epileptic drugs which act here also. Okay, so voltage gated potassium channels, when they open, there is repolarization. Similarly, these voltage gated potassium channels are here as well. Okay, everywhere they are, because here also action potential or depolarization is occurring. So there are also voltage gated potassium channels. Then here nearby I have shown this GABA synapse. Okay, so here again the action potential will be coming. So if there is another stimulus which is causing the inhibition of the synapse, so this will lead to release of the GABA neurotransmitter by the same mechanism, right? And this is going to act on these are GABA A receptor. Okay, when these receptors open, there is entry of chloride ions. Okay, there is entry of chloride ions, and chloride ion is a negative ion. So this depolarization, it is going to decrease. It will move the membrane towards the resting membrane potential, or even hyperpolarize the membrane. Okay, so that is chloride ion entry is caused by this GABA receptors. Then this GABA is taken up by a transporter known as GABA transporter, name is GAT1, and there is breakdown of this GABA as well. So this GABA is broken down into its end products by an enzyme known as transaminase, GABA transaminase. Fine. So this is the basic fundamental how transmission is occurring. Now we will see that what are the drugs which are acting, and you will see that at all of these levels we have anti-epileptic drugs. Fine. So we have this slide where we will talk about the anti-epileptic drugs. So here I told you before that action potential is coming. There is excitation of the neuron terminal, that is by opening of voltage gated sodium channels. So there are anti-epileptic drugs which prolong the inactivation of these sodium channels. See, for sodium channels to open again, they should move from inactivated state to the closed state. There are three states of channel, that is closed state, then they open, and from open they get inactivated. For the channels to open again, they should move from inactivated to the closed state. Otherwise, they cannot open. Okay. So we have anti-epileptic drugs which prolong the inactivation of these voltage-gated sodium channels. What are these drugs? We have carbamazepine, oxcarbazepine, eslicarbazepine, valproic acid or valproate, lamotrigine, then we have phenytoin, then we have lacosamide, and we have zonisamide. Okay, so that is one. Second, we have blockers of this voltage gated calcium channels, and these are gabapentin and pregabalin. They have another action also. They act by increasing the GABA transmission as well. But this is another one where they inhibit this voltage gated calcium channel, a special unit of this voltage gated calcium channel. So if they inhibit it, calcium will not enter and there will not be any synaptic fusion. Okay. Third one is the blocker of this synaptic protein. And what is that? That is levetiracetam. Levetiracetam. Okay, so if it blocks these proteins, basically SV2 protein, synaptic vesicle protein, the vesicle is not going to fuse with the membrane, so there will be decrease in the release of the glutamate. Then we have these voltage gated potassium channel openers. So what are these openers and how do they act? See, voltage gated potassium channel opens, then more potassium will go out of the cell, more potassium efflux will occur. That means repolarization is going to occur faster. So action potential is going to last for very small duration, such that these voltage gated calcium channels will open less. Understanding? So more the depolarization, there will be more opening of calcium channels. So if we reduce that, the entry of calcium will automatically be reduced. So voltage gated potassium channels act by decreasing the depolarization and increasing the repolarization. So what are the drugs which act by opening these voltage gated potassium channels? That is reticabine. Fine. Then there are drugs which block the glutamate receptors, and I told you there are different types of glutamate receptors: kainate receptor, AMPA receptor and NMDA receptor. So this is NMDA receptor. It is blocked by felbamate. AMPA receptor is blocked by perampanel, and kainate receptor is blocked by topiramate. Okay, so these are glutamate receptor blockers. Then moving on to the GABA transmission, there are drugs which help in enhancing the inhibition. So what are these? First one, which bind directly to the GABA A receptor and thus increase the chloride transmission. What are these drugs? So these are two drugs. One is benzodiazepines and the other is barbiturates. Benzodiazepines increase the frequency of opening of these GABA A receptors, which are channels, to increase the frequency of opening of these chloride channels. So obviously more chloride entry will occur. Barbiturates increase the duration of opening of these channels. So we can remember it, durate. Okay. So barbiturates increase the duration of chloride channel opening. So those are other drugs. Then there are drugs which block this uptake of the GABA. So if the uptake is blocked, more GABA will remain in the synaptic space and hence it will be able to act more. So what are these drugs which block this uptake? This is blocked by a drug, that is tiagabine. Then there are drugs which block the metabolism of GABA and they block this GABA transaminase. Hence, more GABA will be available. So this drug includes vigabatrin. Okay. Then finally we have another drug which is blocking this T-type calcium channels. Actually this T-type calcium channels, they are present in thalamus and that is responsible for thalamocortical oscillations. That means excitation of the thalamus leading to excitation of the cortex, and these are responsible in certain seizures. Okay, because this is responsible for synchronous activation of the cortex. Okay, so that I didn't discuss before because these are specific to the thalamus, and when these channels open, then there is some entry of the calcium ions. Remember, T type means that is transient calcium channels. So there is some entry of these calcium ions, and this leads to depolarizations in the thalamus. Okay, so if we block this, then these depolarizations, small depolarizations which are happening in the thalamus will not happen. So this T-type calcium channel blocker includes ethosuximide. Fine. Then we have discussed here valproate, right? So that also acts by inhibiting this channel. Actually, this valproic acid is a broad spectrum drug because it acts by many mechanisms. So it is blocking this voltage gated sodium channels. It is also blocking this T-type calcium channels. Then it also increases the GABA transmission as well. Actually, it increases the synthesis of GABA that we have not discussed here. It increases the synthesis of GABA and hence there is more release of GABA. Fine. So this is the basic fundamental. I understand that right now it might be becoming too much, but when we will discuss each drug one by one, then it will get more simplified. Okay, let us move on to each of the drugs, and we will also talk about that where each drug is used, what are the special features and what are the adverse effects. So these are the individual drugs. First drugs include the sodium channel blockers. So in this we have carbamazepine, oxcarbazepine and eslicarbazepine, which we are going to discuss together. Carbamazepine is the drug of choice for partial seizures, that is the focal seizures, okay, and also drug of choice for trigeminal neuralgia, a separate condition. Then carbamazepine is an enzyme inducer. That means if it is given with any other drug, then it will induce the metabolism of that drug. It is important to know because in many seizures, we give combined therapy. Okay, we combine two drugs together. So we have to be very careful when we are doing that because this carbamazepine, if combined with other drugs, will increase their metabolism. So the metabolic end products are going to rise and there may be more chances of toxicity. So there are three enzyme inducers which we are going to study, that is PCP, that is phenobarbital, the barbiturate, carbamazepine and phenytoin. Okay, so these three are enzyme inducers. Then what are the side effects? We have Stevens-Johnson syndrome, very important, and Stevens-Johnson syndrome is caused again by three drugs, that is, we can remember it by L's, okay, E ethosuximide, L lamotrigine and S here we I make it C, else. Okay, so that is carbamazepine. So that is Stevens-Johnson syndrome. Other toxicity of carbamazepine include bone marrow suppression. So there is leukopenia, anemia, aplastic anemia, hepatotoxicity, and very important, it causes inappropriate release of ADH, excessive release of ADH, which leads to hyponatremia. Okay, so that is carbamazepine. Point to remember, that is enzyme inducer, PCP, and it is drug of choice for focal seizures and trigeminal neuralgia. Then we also talked about Stevens-Johnson syndrome. Then oxcarbazepine and eslicarbazepine, they are also prescribed in focal seizures. And oxcarbazepine, metabolite causing side effect is not produced. When the metabolism of this drug is going on, then there is a metabolite which is responsible for the side effects of carbamazepine. That is not produced with oxcarbazepine, so side effects are less. And eslicarbazepine, important thing is that it has long duration of action and once a day dose is enough. Now, which to choose? I am telling carbamazepine is a drug of choice. Well, there are many things. How much dosing is required and cost is also one very important factor, because this condition requires long-term therapy. Okay, so cost is also one important factor. Then coming to next drug, that is valproate, very important drug, because you see, it is the drug of choice for so many types of epilepsies. Drug of choice for GTCS, that is generalized tonic-clonic seizures, tonic seizures, clonic seizures, atonic seizures, absence seizures, myoclonic seizures. So basically the whole complex of generalized seizures which we study, it is the drug of choice for those, and it is also used in Lennox-Gastaut syndrome. And why it is so important? Because it is acting via so many mechanisms of action. I told you that it is a broad spectrum drug. It is blocking voltage gated sodium channels, it is blocking the T-type calcium channels, and it is also increasing the GABA release. Okay, so these are the mechanism of action, and maybe that's why it is drug of choice for so many seizures type. But very important thing to remember here is that it is an enzyme inhibitor. Okay, in fact this is a question which is asked in so many MCQs, that which drug is an enzyme inhibitor, or what is not true for valproate. It is not an enzyme inducer, it is an enzyme inhibitor. So if valproate is combined with other drugs, then what happens? It increases the levels of the other drugs because it is inhibiting their metabolism. Okay, so it increases their levels. So there might be precipitation of toxicity of those drugs. So it is very important that we carefully monitor the therapeutic level and increase the dosage of the drug slowly when we are combining these drugs with valproate. Okay, but valproate has a very broad toxicity profile as well. So I remember it by the term valproic itself. Valproic, okay. So L is for liver toxicity, hepatotoxicity. P is very important, it is pancreatitis. PR for pregnancy, and also for P for PCOD in females. Then RO, I remember that the person becomes rounder, there is weight gain. Okay. So these are the side effects of valproic acid. And remember that it is causing PCOD. There is hyperandrogenism. So if it is to be given in young females, then there might be interference with the fertility. Okay, so then we have to choose that which drug to use. So that's why we should remember the toxicity profile of the drugs, because then the choice of the drug is made. For example, in a patient with liver disease, then we should not give carbamazepine and valproate, isn't it? So we have drug of choice, but also other first line drugs also available and alternatives as well. Moving on to next drug, that is lamotrigine, which is again the first line treatment for all the seizures which we discussed in valproic acid. So GTCS, myoclonic, atonic, everywhere it can be used, plus also focal seizures. But remember, lamotrigine is, again, there are chances of Stevens-Johnson syndrome, and in fact rash occurs in so many patients. The lamotrigine is started. Approximately 10% of patients present with rash, and especially if lamotrigine is given with valproic acid. Valproic acid is enzyme inhibitor. In that case, the levels of lamotrigine are going to rise. So there are high chances of Stevens-Johnson syndrome. Okay. Then it also causes insomnia, headache. Now this is contrast from that of the valproic acid, because valproic acid is a drug which is also used for migraine prevention. Okay, so valproic acid, just another one more information. Okay, then we have lacosamide, zonisamide, which are used for refractory focal seizures. Okay, not the first line. If the seizures are not responding to other treatments, then lacosamide and zonisamide can be used. And how remember the side effects? You see, zone. So zone is stone. So zonisamide can lead to development of renal stones. Then moving on to other drug, that is phenytoin. Phenytoin now is not used as first line treatment because of vast adverse effect profile. So only in refractory cases it is used. So what are the adverse effects of phenytoin? Just to remember the name, phenytoin. Toin, it cannot be given in pregnancy because it causes fetal hydantoin syndrome. I forgot to tell there that valproic acid we cannot use in pregnancy. There was written pregnancy. It cannot be used in pregnancy. That is the adverse effect because it causes neural tube defects. Okay. Here phenytoin when used in pregnancy, it causes fetal hydantoin syndrome. Then other side effects include that phenytoin causes release of platelet derived growth factor, which is why that now phenytoin is also being seen to have some effect in improving wound healing. However, because of this PDGF, it also causes gum hyperplasia. Then there is coarsening of facial features. And H means hirsutism and hyperglycemia. So if you see all these, it is basically interfering with the appearance also. The gum hyperplasia, coarsening of facial features, hirsutism. Okay, then H again for hyperglycemia. Then it also causes decrease in vitamin D, vitamin K. So vitamin D decrease leads to osteomalacia, vitamin K deficiency and folic acid deficiency as well. So there is megaloblastic anemia. PH I remember, Pho, we pronounce it as phenytoin. So Phe is there, so that is F for folic acid. Okay. So coming to the features now, what are the features? Phenytoin is an enzyme inducer. Before I told PCP are the enzyme inducer. P for phenytoin, carbamazepine and phenobarbital. This phenytoin is having long half-life, so it can be given with once a day or twice a day dosage. And very important to remember, very important, high yield, that it follows non-linear kinetics. That means that as the drug dosage is increasing, its metabolism is increasing, but after some time it reaches that saturation. Okay, so metabolism doesn't increase in proportion to that of increase in the dosage. So even with a small increment of the dosage, the levels in the blood will rise tremendously, reaching to toxic levels. Fine. So that was about phenytoin, and this covers all our drugs about voltage gated sodium channel blockers. Moving to voltage gated potassium channel openers. What are these? There is topiramate and there is retigabine. Topiramate is for Lennox-Gastaut syndrome and retigabine is also for Lennox-Gastaut syndrome. Topiramate, I told you before that mechanism of action is that it blocks the kinase receptors, but there I didn't tell you that topiramate also causes opening of voltage gated potassium channels. Okay, what is the side effects? In zonisamide I told you zone stone, so here also toe. Okay, so it also leads to the development of the renal stones, and P is for psychomotor slowing. So topiramate, so that is psychomotor slowing, and also glaucoma. So anybody who has high risk of development of glaucoma, topiramate cannot be given. Then retigabine, what are the side effects? Red for retinal toxicity, and A here is for anuria, and B is for blue pigmentation of the skin occurs with retigabine. Moving on to the next drug, that is the drugs which prevent synaptic vesicle fusion. So here we have levetiracetam, which is given for focal seizures. Okay, and very important feature you should remember that with levetiracetam not many drug interactions are seen. So it can be given in elderly who have various comorbidities and might be taking drugs for other diseases. So that drug-drug interaction is not there with this levetiracetam and is a preferred drug in elderly. Also, it is preferred in pregnancy. And what are the side effects? Side effects include irritability, emotional lability, emotional changes will be there. Other psychiatric features can also appear. So anybody who has a learning disability or has got treated for previous mood disturbance, this drug cannot be given. Okay. Then next, glutamate receptor blockers. So what are these? This I told you before, topiramate, felbamate and perampanel. Out of this, topiramate and felbamate, they are both used for Lennox-Gastaut syndrome. So simple, you remember, voltage gated potassium channel opener and glutamate receptor blocker. They are for LGS. Okay. Voltage gated potassium channel opener and glutamate receptor blocker for Lennox-Gastaut syndrome. Then moving on to the next type, that is T-type calcium channel blocker. So here we have ethosuximide, which is the drug of choice for absent seizures in less than 2 years of age children. See, I told you valproic acid is a drug of choice for absent seizures, right? But valproic acid is not given at to children less than 2 years of age because there is high risk of development of hepatotoxicity. So in those children, we give ethosuximide. And what is the side effect? I told you before, Stevens-Johnson syndrome, that is seen in ELS. Okay, ELS. So we have ethosuximide, lamotrigine and SE for C. Okay, that is carbamazepine. Then moving on to the next class, that is the GABA receptor agonist. We have two types, that is benzodiazepines and barbiturates. Benzodiazepine, before I told you, increase frequency of opening of chloride channels, and they are the drug of choice for status epilepticus and febrile seizures, right? And what is the side effect? Sedation, tolerance, addiction. That is why they are not used in other types of seizures. So only for short term, for control of acute seizures, benzodiazepine is used. Okay. So status epilepticus, drug of choice. Then barbiturates, again, they are used in status epilepticus and they are the drug of choice in generalized tonic-clonic seizures in neonates. Phenobarbital is given. Okay. Neonates and infants. Then what are the special features of barbiturates? Again, it is enzyme inducer. Remember PCP for enzyme inducing drugs. And these barbiturates are contraindicated in patients with acute intermittent porphyria. And side effect, MCQ comes often, that it causes hyperkinesia in children. Okay. Moving on to the next, that is the GABA uptake blocker, GABA transporter blocker, that is tiagabine. That is again alternative drug for focal seizures, right? Then GABA transaminase blocker, that is vigabatrin, and that is used only for refractory epilepsy, mainly for focal seizures with secondary generalization. That means focal seizures which started at one place, but then they spread to other hemisphere also. So they are looking like generalized epilepsy, generalized seizures, but they are the focal seizures because origin is from one cerebral hemisphere. So what are the side effects of this vigabatrin? Vigabatrin, VI for visual field defect. So with long-term consumption of vigabatrin, there is channeling of vision. Okay, so that is visual field defect. The other name is just telling you the mechanism of action. You see GABA, TR is for transaminase, IN for inhibitor. Okay, vigabatrin. Then there are drugs which increase the GABA release, that is, these are gabapentin and pregabalin. As I told you before, they also block the voltage gated calcium channels, right? So these are the drugs which also increase the GABA release, and again they are used for refractory epilepsy, that is focal and that with secondary generalization. Same like vigabatrin, okay? So we'll just summarize this, that which is the drug of choice for what, too much again to handle, but I have given lot of mnemonics for you for the important things, right? Like which is the enzyme inhibitor, which are the enzyme inducers, and what are the side effects. Then very important to remember that what are the special features of the drugs. Drug of choice, again we are going to summarize here so that you remember better. So for focal seizures, drug of choice is carbamazepine, oxcarbazepine, and there are so many alternatives. Very important, lamotrigine is coming up as first line drug for so many different types of seizures. Then levetiracetam is there, which I told you that it is preferred in elderly, right? Then phenytoin, if it is refractory seizures because of so much adverse effect drug profile, we have to monitor very closely. However, phenytoin has a very long half-life. Okay, so the dosage frequency is much lesser. Then we have generalized tonic-clonic seizures, valproic acid and lamotrigine is the drug of choice. Then myoclonic atonic seizures, we again have valproic acid, lamotrigine. Remember valproic acid for all the categories of the generalized seizures, generalized tonic-clonic, myotonic, atonic, clonic, absence seizures, everywhere. Valproic acid and lamotrigine are used. Remember in myoclonic, contraindicated is carbamazepine and phenytoin because they increase these kind of seizures in myoclonic. Okay. Then absence seizures, same valproic acid and lamotrigine, but less than 2 years of age, we have ethosuximide because there is high chances of hepatotoxicity. Then we have Lennox-Gastaut syndrome where again valproic acid is used, and I told you other drugs, that is the voltage gated potassium channel opener and glutamate receptor blockers. Okay, so this is topiramate, felbamate is NMDA receptor blocker, then topiramate is voltage gated potassium channel opener. Okay, but apart from these there are certain newer drugs, that is cannabidiol, and this is CB1 receptor agonist, newer drug which is approved, and rufinamide. Okay, rufinamide, we don't know the mechanism of action. Then coming to status epilepticus, that is the acute control of the seizures. During seizures, to control that, what is used, because sometimes the seizure activity may prolong. So that time it is important to control it. So we have benzodiazepines, phenytoin and barbiturates for acute control of the seizures. So that is about the various anti-epileptic drugs. Fine. Now, how to approach for treatment? How to approach for treatment? Simple, we will just summarize in 2 minutes. One is, first is treat the cause. If there is metabolic cause, if there is focal cause, you have to treat the cause. Otherwise, add anti-epileptic drug. First, you add anti-epileptic drug and monitor the dose. Slowly, you have to increase to see what is the therapeutic level. Then, if the seizures are not controlled with one drug, then you go for another drug. Okay, and you have to increase the dose slowly, go slow. When the therapeutic level is reached, then you remove the first drug. Okay, suppose it is not controlled by that, also try another drug, or also we can try combination therapy. Okay, again combination therapy, we should know about the side effects of each of these drugs, because based on that only we have to combine. So we cannot combine two drugs which are having hepatotoxicity. Then if we combine drugs with the valproate, we have to monitor for the toxicity, because valproate is enzyme inhibitor. Okay, so basically the choice of drug will depend on what are the comorbidities, what is the profile of the patient, young patient, then which drugs to give, pregnant patients, which drug to give, elderly, which drugs to give, what are the side effect profile of the drugs, right? Then whether the drug is enzyme inducer or enzyme inhibitor, then what is the dosing frequency of the drug. So all these things you have to take in consideration for treatment. And when can the drug be discontinued? That can be discontinued if there is 2 year no history of seizures. Okay, no history of seizures, but that is not the only criteria. Along with this criteria, 2 years seizure free, along with this criteria, we should have other criteria as well, which should be fulfilled. That includes no family history of seizure. Okay, no family history. Then only single seizure type. There are syndromes of epilepsy in which the seizure is mixed. Multiple types of seizures can be there. Then we have normal neurological function. Okay, even the intelligence should be normal. Normal neurological function and normal EEG. Okay, so if the person is seizure free for 2 years along with these criteria, then the drug can be slowly tapered off and it can be withdrawn. So that was all about the anti-epileptic drugs. I hope you liked the video. If you liked it, do press the like button. Do share the video with others who want this knowledge to be gained. And don't forget to subscribe to the channel Physiology Open. Thank you.